All right. Those are the real common players as far as causes of ST elevation. We're going to look at a few maybe less common ones now, which can still be important. All right, Brugada Syndrome. This was very poorly known as little as maybe 10 years ago, but it's getting more attention recently. It's really a certain pattern of findings on the EKG, which has been shown to be a risk factor for sudden cardiac death, really through VF or often a polymorphic sort of VT. It was initially described in the early 90s, really through this rash of sudden deaths among young, healthy folks in Southeast Asia. But it's been studied since. It's understood a lot better. It's thought to have a sodium channelopathy as the etiology. But the real problem here is that people who have this at their baseline, and it's something that you're born with, they're at risk for suddenly going into pulseless arrhythmia and maybe dying. How high is that risk? Well, it depends. If there's any history of syncope, people passing out probably through a transient arrhythmia, we know that those people are at more risk, maybe upwards of about 8% chance of death every year. So when they find this, they usually do an electrophysiology study to help stratify their risk, and they may get an ICD placed. So what does it look like? It is a certain pattern of elevation, usually in leads V1, V2, maybe V3, with a particular shape, and I'm going to show you that. But overall, it may look similar to a right bundle branch block. It can shift around a little bit, and that's one of the ways that they deal with it in the EP lab. They may give some antiarrhythmics to induce certain changes, and it can depend on rate and other things. But the real hallmark shape is most visible in maybe V1, but especially V2. V2 should be your Brugada lead. And this is what it looks like. You'll see it in the other leads, it looks maybe a little bit funny, but look at V2. This is Brugada. It's got this tall peak and it down slopes forward. This is not a normal amount of or shape of ST elevation. It's got this slope that rolls forward. Now you see there's different types. You got type 1, 2, and 3. 2 and 3 are lower risk. And this is the kind of thing they may play with in the EP lab and decide what to do with it. But they may not have a substantially higher risk of death than anyone else. They have more of this kind of coved shape. But type 1 is what you should be focusing on. These are the people who may suddenly go and die on you. And they have this really distinct shape. So I want you to take a look at that, burn it into your mind. You may not see it often, but if you do, it should jump out at you. So what do you do with it? Understand what it looks like. When you see it, you should recognize it. I'm not saying you should go digging for it. Maybe on your younger patients who have syncope, it should be closer to the top of your mind. But if you do see it, first of all, you got to recognize that it's obviously not a STEMI. But second of all, you should make sure that these patients are actually getting a visit by cardiology, because this may be their only chance to catch that. And you don't want to miss it, and then 2 years later that guy dies on the lacrosse court or something. It's sort of the evil twin of benign early repolarization. It's not benign, but it's in the same category of patients. Young, healthy folks, they got a life ahead of them, but this may be the only chance they have to get a 12 lead done. You're really screening for this. So if you catch it, make sure you pass it along to somebody at the ED. And no matter what the original complaint was, maybe they came in for a broken ankle or something, this is their chance. You caught it, and they should get seen for it. All right. Head injuries, or maybe the intracranial bleeds or strokes. Whether it's traumatic or not, these type of patients actually have a very high rate of some sort of cardiac dysfunction, maybe up to 100%. And you will see it on the EKG. What does it actually do clinically? Some degree of heart failure, really. And the idea is there's some sort of stunning of the heart, maybe from a massive influx of catecholamines. There's a spasm of the coronary arteries. That's the general theory here. But what are the effects? It's sort of a transient stunning. The heart stops working particularly well for a little while. And it can look differently, but there's kind of a classic look which has these very huge, deep inverted T waves. Neurogenic T waves are sometimes called. and there can be various other changes. Sometimes it actually has an Osborne-type wave, which you'd associate more with hypothermia usually. But the point is, if you see this on maybe a MVA patient, somebody got hit by a baseball bat in the head, don't think, oh gosh, maybe he had a heart attack and that caused somebody to hit him in the head with a baseball bat. Most likely, it is just a side effect of the head injury. Now, of course, there is a possibility of both things happening at the same time. Maybe he had a heart attack and then he crashed his car. So give that some thought. But don't start thinking you have to bring this person to a cath lab instead of to a trauma center. The problem is still the original problem. And as far as support, there may be some element of cardiogenic shock here. So they may need support as far as inotropes or fluid. You know how to do that. But treat him as a head injury patient. Don't get too worried about some zebra, which is also present. Aortic dissections, up in the chest, not down the abdomen. Now, these are tricky. These are dangerous. They do kill people, and they can look like MIs, but they're treated very, very differently. And the trick is that they look similar in a lot of cases. But if you can't figure out the difference, these people may not do well because they're going down such different treatment paths. In the case of the MI, they need reperfusion, maybe thrombolysis, aspirin, things like that. In the case of the dissection, they need surgery, and really they need to limit their bleeding, not encourage it. So, can it look like an MI on the 12-lead EKG? Yeah. Why? Probably because there's a physical impingement upon the coronary arteries, which are on the surface of the heart. When the aorta balloons or widens in a retrograde fashion, so it pushes backwards and ends up pressing upon the surface of the heart and presses down on some of those arteries. And there's a couple similar mechanisms, but that's the general theme. So it is ischemia. You are blocking off arteries, but it's not because of a clot or other occlusion in the artery. It's from the outside. So clinically, there's nothing that will really tell you what's going on. The most predictive features are what the pain is like. More than 80% of people will say it's abrupt, so it started all of a sudden, and it was at its maximal severity right away. It didn't slowly develop. It wasn't worsening over a few hours. They were sitting there, and all of a sudden they had this terrible pain, and a lot of them will just describe it as the worst ever, the worst pain they've ever had. At least half will say it's a sharp or tearing pain, maybe ripping. That's very descriptive. Not everyone will say that, but when you do hear it, it should make you think dissection. Almost everyone will say it's in their general chest area, sometimes in the back, but in the thorax, let's say. A lot of them are hypertensive, mainly because hypertension is a risk factor for getting these dissections. A lot of us have been taught that these patients may present with a differential in the pulse or the blood pressure between their arms. So you take a pressure on their left arm, it's 130. You take it on their right arm, it's 190, something like that. That can be present, but it's neither very sensitive nor very specific. So don't get too worried about it. I would not myself even look for it, but it's something you could think about. Now on the EKG, what are you going to see? Nothing very specific. A lot of them may have an LVH appearance just because a lot of them have hypertension, which can lead to the LVH. It's not like it causes dissections, but it's a risk factor. A few of them will have elevation. Many more will have more like an ischemic change with depression and T-wave inversion. Often it's in the inferior leads, occasionally in the lateral leads, so it does have anatomical localization, but there's nothing that really will be distinctive. So these are tough. It is high stakes. You do want to have your eye out for it. Never forget about the possibility, even if you're thinking about mainly MI. But if you really do think, when everything is considered, that it's more likely to be a dissection, consider the places you can bring them and try and get them to a facility where they can operate on them. It's tough. I don't have any silver bullets for dealing with it, but it's something you should try and keep in mind. All right, Prinzmetals, or vasospastic angina. This is not very well understood yet, but it's basically a sudden, spontaneous vasoconstriction of the coronary arteries. A very similar syndrome can be produced by cocaine, but the idea here is that it's not an occlusion, it's just the arteries spasming shut. Now, unlike typical angina, It just comes upon arbitrarily. It's not caused by exertion or anything else. And often these people do have some degree of coronary artery disease, so some baseline narrowing, but the symptoms will be radically disproportionate to how much stenosis they actually have. So maybe they're used to having some angina when they exert themselves, walk upstairs, but this will be real sudden and disproportionate. Usually it's pretty benign. These people don't go in dying of this for the most part. Sometimes when there already is a significant amount of stenosis, they can have problems. But for the most part, this is only a problem because it makes us think about MI. What does it look like? Often some elevation, but usually very little. Occasionally there will be significant amounts. I've seen up to maybe 5 millimeters, but that's pretty rare. Maybe some T-wave inversion. Occasionally you'll see inverted U waves. That's kind of an unusual feature. But the big thing is that it's transient. Usually it lasts only a few minutes long. And once it finishes, EKG changes should diminish as well. Sometimes you'll see some T-wave inversion and it lasts a little while. But if you get in there maybe a few hours after it started, the pain is still going on, you have findings on the EKG that look ischemic, that's not really classic for Prinzmetals. So the key points are, even if it's a sort of atypical syndrome, it's still angina, so it still acts like angina. Nitro often works quite well. It's nice to get your 12 lead before you give it because it may normalize, but it will really be resolved, which is again a feature of angina. It should be transient, like we said, so try and get those serial EKGs. If it's still going on quite a while later, you should start thinking about something else. Now, it may not be easily distinguished from an MI, which is aborted or spontaneously reperfuses, and obviously those patients do need care because they're at high risk for another event. So play it on the safe side. All right, WPW. This is, of course, caused by an accessory pathway of conduction. It allows excitation from the atria to the ventricles other than through the AV node, as it ordinarily will be. It's bypassing that. There's no delay as we would normally expect from the AV node. Because we're getting conduction from usually the side, it can look like a bundle branch block with that widening, and for the same reason you can see some elevation. Now, it is not itself an MI, but it can be a risk factor for death. Some of these patients will have sudden death in the same way that the Brugada patients may. And that's because the reentry pathway can cause various arrhythmias which are not perfusing. So the big points are, first, you got to realize that it's not a STEMI, and second, you may need to provide care for antiarrhythmic treatment. What does it look like? It may be somewhat wide. Often it's not quite wide enough that you would call it a bundle branch block, so maybe a little bit under 120, maybe 110-ish, but there's often a slurring to the QRS. It's called a delta wave. Instead of a nice straight diagonal line, it looks like two lines that are merged because it actually is. You have the excitation from the reentrant, the accessory pathway merging with the excitation from the AV node. So it can be sort of curved or look like there's an angle in it. And there should be a very short PR interval, because instead of delaying at the AV node, we're going directly into the ventricles. It may look like the P wave is really almost joined with the QRS. If you want a number under about 120 milliseconds, is considered short. Now, it can look like LVH. Sometimes it gets confused with it. Depends on where the accessory tract is. It tends to follow a Scarbosa-like discordance, but not always, and it's not super reliable. So try to recognize it right off the bat. Look for that delta wave, look for that short PR. You can try and use the Scarbosa approach. Don't rely on it too much, but keep an open mind. If you're pretty sure that there is WPW, be pretty skeptical about there also being a STEMI. Maybe there is, but much more often the symptoms of maybe chest pain are related to arrhythmia rather than to an occlusion. So this is a fairly typical WPW appearance. You see a very short PR, so the P wave is really right up against the QRS. There's really no straight PR segment there at all. It's just merging right in there. You have a wideish QRS. This one actually looks like a left bundle. And you have a delta wave. Look at maybe V2. You have one stroke here, then an angle, and then another stroke. So it's curved, or there's actually an angle in the middle of the initial segment there. This is more subtle than it sometimes is, but you can definitely see it. And you also see there's elevation or depression, which is discordant from the QRS, and that can be the case. So pretty typical appearance here. Hyperkalemia. Now, hyperkalemia is tough. It's been called the great mimic, or the syphilis on the EKG. It can look like a heart attack, and it can also kill people. So you want to be able to catch these, and it's really actually very amenable to treatment in the field. It's maybe the only abnormality of electrolytes which you can and should be managing out there, because it can acutely kill people, but you can really readily address it. So anytime you go to a patient who you know has renal insufficiency, maybe someone who's on hemodialysis, you should be thinking about hyperK, because it's very common for those people to develop it, especially if they're missing treatments. They start to build up that potassium. Also, maybe anybody who's on a potassium-sparing diuretic, so they're peeing out a lot of fluid, but they're retaining their potassium. Anybody with those types of issues. Potentially also trauma patients with maybe crush syndrome or severe burns, they can get a lot of potassium in there as well. You want to recognize it, and of course you don't want to be treating it as an MI, because that can cause problems as well. So what does it look like? It can look like anything, but classically, especially early, you're seeing hyperacute T waves, but not like hyperacute T waves of MI. They're pretty symmetrical. They're very narrow, and they come to a sharp point. And usually, if you can see the shape of the ST segment, it's more concave than a bulging convex ST segment of an MI. So this really these tented, spiky T waves that's going to stand out as the hyper-K indication. Now, what's tricky is as it gets worse, it starts to get more bizarre. Everything widens out some, and that can obscure that narrow spikiness of the T waves. So the worse it gets, the trickier it is. But at that point, it shouldn't really look like an MIU. It should look like just a messed up strip. So you can compare these two here. You see in the hyper-K, very narrow, spiky T waves. They're very symmetrical. It looks like you have a post holding up a tent here. In the MI, they're a little bit asymmetric, and they're wider. It's that fatness you associate with a hyperacute MI T wave. So this is really something you got to look at, but after a while, this should jump out at you as being really too narrow and spiky for an MI. Now, I just want to demonstrate that as potassium climbs, obviously the hyperkalemia worsens, but this is not always associated with direct changes on the EKG. You can see really severe changes at relatively low potassiums, or you can get way up there and not see too much on the EKG. So this patient has about a 7.1 potassium. You see these very sharp, spiky T waves. P waves are almost non-existent at this point. So this is pretty advanced. This is even worse, 8.5. You see very spiky T waves still, but you see everything is starting to widen out, and that would make it a little bit tricky. But it's starting to follow that classic sine wave of hyperkalemia. It's just kind of down, up, down, sort of a Z pattern. You should not ever look at this and think someone's having an MI. You should think, oh, we need to treat them for hyperkalemia. This is over 9. We're starting to lose voltages now. It's just kind of a more subtle sine wave pattern. And this should really make you think you want to treat them. Now, again, compared to the MI, look at this. You got the fatter, more asymmetric T waves. Otherwise, it's a more normal pattern. You still have P waves and so forth. These are not the same thing. Now, important points are you should be thinking about it. You should recognize that it can look like anything. So in these patients that you know are at risk for it, like the dialysis patients, they should always be on your mind. Look for those T waves. That's your best clue. When it gets more advanced, it's going to be harder to gauge, but it should start looking really, really bizarre. So if you think you have hyper-K, don't treat it like MI. Look for arrhythmia, and these patients need, more than anything, calcium. There's a whole cocktail of drugs we usually give for hyper-K, maybe calcium, sodium bicarb, they need fluid, maybe insulin and dextrose or glucose. We don't really give insulin in the field. Kayexalate is often given, albuterol, etc., etc. But calcium is by far the most useful drug for acute management. You give calcium, you will often see a very rapid resolution on the EKG of these signs, and that can really prevent them from going into a life-threatening arrhythmia. All right, Tako-Tsubo. This is pretty cool. It's gotten better known in recent years, but it was first described in Japan, hence the Japanese name. And Tako-Tsubo is actually what they call an octopus pot. I'm going to show you a picture of that. But it's also known as stress cardiomyopathy. Transient apical ballooning is a more formal name. Ampulla cardiomyopathy is maybe less used now, or colloquially is broken heart syndrome. It most often occurs in postmenopausal women, but it can be in anyone, and it's often patients you wouldn't think are at high risk for a cardiac event, so often younger folks. And what it is a stunning of the myocardium, but it's differential. It's not the whole heart. And this is an octopus pot, a Tako-Tsubo. They use them in Japan. An octopus climbs into the mouth here, and because it's narrowed, they can't climb back out, so it's an octopus trap. But here is the heart in Tako-Tsubo Cardiomyopathy. You see you have contraction through most of the heart, but in the apex, so down towards the tip, there's very little contraction, so there's a stunning. So you end up with this funny pinched shape near the top where there's still round near the bottom. And that's the hallmark of this type of cardiomyopathy. And what it's caused by is stress. That's why they call it broken heart syndrome. Classically, you have maybe an older woman whose husband of 30 years dies, and then suddenly they're having chest pain, and you take their 12 lead and they have elevation, and you go, oh my gosh, she's having a heart attack. But in fact, she's not. She's having Tako-Tsubo. And now that stress is not always like that. It can be very acute like that and emotional, but it can also be physical, maybe a physical event like a near drowning, or a traumatic event, even drugs, and even fairly chronic stress often causes it, maybe with some precipitating factor. The tricky thing is it can look like an MI in pretty much every respect. It can look clinically like an MI. The EKG can look like an MI with reciprocal changes in everything, and even elevates biomarkers, so they will have elevated troponins. So for the most part, these patients are diagnosed when they go to the cath lab, they go in there and they don't find anything. So I'm not saying these are patients you should be catching in the field and ruling out. For the most part, even if you suspect Tako-Tsubo, they're going to go down that pathway. In general, it may look like Prinzmetals with maybe a little bit of elevation, kind of those funky inverted T waves. That's not uncommon. But it's not totally understood. Like I said, it's felt to be some sort of vasospasm, maybe through a catecholamine response, much like in those head injuries. Really a similar, at least theorized mechanism. As far as harm, it's usually pretty benign. Much like the head injuries, if there is harm, it's from heart failure, just this acute stunning. In that acute phase, the ejection fraction may be less than 40% or so, which is not so bad, but certainly symptomatic. As long as they make it through that initial period, they usually do fine. In some cases, they may need support just to get through that acute heart failure. But if there is some sort of acute stress, it's something you could think about, but don't worry about it too much. They're still going to get cathed most likely, and that's fine. These are not bad false positives. These are acceptable false positives. All right, and that is the majority of what we're going to look at. Those are all the real common mimics and the general approaches for dealing with them. Just to bring it together, I know we talked about a lot, but in general, start with the history. Is this the kind of patient you would expect to have a problem like a heart attack, or maybe something more congenital? Are they real young? Maybe they wouldn't have found something like Brugada yet. Are they real old and you'd expect them to have a coronary occlusion? Does something provoke it? Can you get an old EKG, or do you know that they have an existing problem? Look at the clinical presentation. Is it real classic for MI or more consistent with something else? Is the pain sharp, pleuritic, tender, something like that? Get an early 12 lead if possible before you treat, and then keep doing those serial 12 leads. What do you see? Does it look like MI? What is the morphology? Are there reciprocal changes? What's the computer think, especially when you have that Marquette algorithm in there? Does the EKG look like anything else? Does it have an appearance of hyperkalemia or WPW or anything else? Do you think it's more likely that it's that or that there's an MI? And even if you think it's something else, could there also be an MI? Remember, those are different questions. It's one thing to say, is it left bundle or an MI? That's pretty easy, but it's harder to say, given that there's a left bundle, is there also an MI there? If there's something else you think, is it equally or more dangerous to the STEMI? Maybe the Hyperk or the dissection, you don't want to miss those. So get your serial 12 leads, consider the possibilities, and that depends on your local situation, where you're transporting to. Maybe you have to decide between a trauma center or a STEMI center, or your STEMI center is maybe an hour away, so you got to consider the risks and benefits. If you need to, talk to med control, and make sure when you get wherever you're going, you show them what you found, because they may not be looking at the same things. They may be on a very different track. They may not be thinking about things like Brugada, so make sure you give that to them. Turn over your early strips if you can. And that is it, folks. Thank you for joining me on this. I'm happy to answer any questions in the comments here or by email. A few quick acknowledgments. Tom Boutelet, who runs EMS12lead.com, he's a fire captain and a paramedic down in South Carolina. Really been a pioneer as far as EMS education on the EKG, and has really helped bring these advanced types of interpretation back to the forefront. Dr. Stephen Smith, who we keep talking about, has done a ton of the work in developing these evidence-based rules. Again, really a pioneer as far as making this a real way we can make decisions instead of relying on labs and waiting and seeing. And in general, all the other researchers who have done good stuff in this field, Dr. Brady, Scarbosa, Dr. Matu, and so forth. These people are helping us a lot and really bringing this back to an art that we can all be using. So thanks for joining me, and let me know if you have any questions.